Good evening, everybody. My name is Thomas Engstrom. I'm a professor in cardiology in Copenhagen, and it's a true pleasure for me to chair this session, which bears the title, Coronary Physiology in Stemi, is Opsens OptoWire III a game changer in complete revascularization? And obviously, this deals with Stemi patients and the matter of a complete revascularization after having dealt with a culprit lesion. I'm very proud also to introduce the discussants in this session, which will be Dr. Jacques Monsegu from Grenoble in France, will be Dr. Giuseppe Biondi-Zoccai from Latina in Italy, Dr. Zsolt Piroth from Budapest in Hungary, and also Dr. Peter Smits from Rotterdam in the Netherlands. Dr. Piroth will also be our chat master, and please don't forget to pose questions via the chat. Dr. Piroth will then answer them as good as he can, meaning if he's doing the best to answer most of all your questions. And he will also push further on questions to the panel to be discussed subsequently. So with no further ado, I'll introduce the first speaker, who will be Dr. Giuseppe Biondi-Zoccai, who will present our first case. Thank you.
This is Giuseppe Biondi-Zoccai from Latina, Italy, presenting you our experience with the use of Opsens medical guide wire for Stemi at the index procedure. This is my disclosure. Indeed, we've been using the approach of appraising the functional significance of non-capillary lesions during Stemi for a while, as testified by the study design of the WAVE registry, led by Dr. Musto. Basically, we performed the functional assessment of non-capillary lesions in Stemi patients and let these results guide either ad hoc PCI or stage PCI or medical management. The results of the WAVE study are almost available. The study has been submitted, and I can anticipate you that this approach was feasible and safe in almost 300 lesions and more than 200 patients. Indeed, this brings us the importance of DPR. This is a functional index, non-hyperemic one, for the appraisal of coronary lesions. It is based on the ratio between PDPA at diastole and PDPA at whole cycle. The key novelty is the third generation of OptoWire. So this guide wire can enable the measurement of DPR. It is very user-friendly, torqueable, and it has other important features: the capability to connect and disconnect multiple times, a consistently low drift, and the availability of pullback. This means that OptoWire 3 is very promising in comparison to other guide wires, which can be used to measure the functional significance of coronary lesions, and also it can be used as a workhorse guide wire. Indeed, DPR measures the functional significance of coronary lesions in a manner very close to IFR, and indeed DPR is a better estimator of IFR than PD-SUPA, as shown in our recent study available in Palminerva Medica. Similarly, DPR is closer to IFR, and it can be repeated multiple times in terms of measurements, with very close measurements, even if measured, obtained independently in different times. And this brings us to the cases. The first case is a routine case, is a patient with anterior Stemi with mild LAD culprit and a non-culprit posterolateral. As you can see, the PL is diseased here. And this is the left coronary angio. You can see the culprit LAD totally occluded, and also there was catheter damping in the left main. So what would you do? Would you do angio-guided PCI of LAD? Would you do angio-guided PCI of left main, LAD, and posterolateral? Would you do IVOS-guided PCI of left main, LAD, and posterolateral? Or would you do DPR-guided PCI of left main, LAD, and posterolateral?
Thank you very much, Giuseppe, for this interesting case. Please use your app now to vote which of the 4 solutions that you would choose. Recall that solution A is angio-guided PCI of the LAD. Number 2, angio-guided PCI of LM, LAD, and the posterolateral branch. Number C, IVOS-guided PCI of left main, LAD, and posterolateral branch. Or D, DPR-guided PCI of left main, LAD, and the posterolateral branch. And while the poll is ongoing, I'd like to address one classical question to Dr. Peter Smits. You have a number of experience from your compare-acute study, and one question that always arises is, can you actually use physiology in measuring a culprit area during primary PCI?
Okay, Thomas, that's an interesting question. You are asking whether we can use a physiological assessment of the culprit area, if I understand you correctly. So it's not the non-culprit area or the non-infarct-related area that you're asking about, but it is the infarct artery that you're asking about, correct?
Yeah, so that was one of the solutions.
Yeah, well, that is actually a topic that has always been, more or less in the literature, has always been an area that we should not proceed for physiological testing, because of if you are testing in the infarct-related artery area, then probably the microcirculation is damaged by microthrombal emboli and maybe some edema and maybe already some inflammation. So it's always questioned about whether what is the validity of a physiological assessment of the infarct-related artery if you want to assess lesions proximal or distal from the culprit lesion. And in that respect, I would not do personally. But to be honest, there is little literature actually about whether what is done on this, if you can actually do physiological assessments of lesions proximal distal from the culprit lesion.
Thank you. So obviously we have a challenge here because reopening LAD will leave us with an open question regarding the left main at least. What would you do in this case if you reopen the LAD and look at the left main subsequently?
Well, Thomas, indeed, it is an interesting case, proximal occlusion of the LAD, so probably a large anterior wall infarction and multivessel disease. You saw the distal right, which had some intermediate lesion distally, very distally, and also some collateral filling. I saw from the left. I believe it was the circumflex. And then of course you have this potential lesion in the ostium of the left main. Definitely, I would personally would go for an angiographically guided treatment of the proximal LAD, like many I think of us, and whether I would use physiology assessment of the ostium of the left main. Potentially, I would not do. I very much depends on the size of the infarction, the clinical situation of the patient, whether I would proceed to doing additional procedures on the left main or on the right. Looking at the proximal LAD occlusion, I would potentially favor more a stage procedure in this case than doing all in one.
Thank you. Can we see the result of the poll? Otherwise, I have it on my iPhone here. 53% voted for angio-guided PCI of LAD, 20% for IVOS guidance of left main, LAD, and posterolateral branch, and 20% for DPR-guided PCI of left main, LAD, and posterolateral branch. and only 9% went for angioguidance of all of the lesions. So do you have anything to add with regard to culprit physiological assessment? I believe if the pressure drop is negative, you can't rely on it. But what if it's positive? Can you use that information for anything?
Yes, in that case, I would then. In that case, then you can, of course, then you can already assess that specific lesion is highly likely to be physiologically important. But if the assessment is borderline or is above the threshold, then you cannot say anything whether it's going to be physiologically important after the recovery of the distal bed, the distal vasculature.
I agree absolutely. The negative predictive value of an FFR or any physiology index in the culprit artery is probably not dependable, and most of us are reminded not to do it. It's only for the non-culprit territories. On the other hand, if it's positive, it's pretty dependable, I think. But in this case, we also have to take into account other factors, other clinical factors. And I think all of us would do the LAD in this case first as a culprit lesion and see what's happening to the patient, how he's doing. And of course, complete their vascularization early on.
Okay, let's see what the solution was in this case. Let's have Giuseppe's second talk.
Indeed, we performed something in between. So after RCA angio and LCA angio, we performed POBA on the mid-LAD with a B&W guide wire. Then we checked the left main with IVUS and found it was not significantly diseased. Then we completed with stenting of the mid-LAD using the B&W. Then we opted to check for the functional significance of this lesion on the diagonal and use DPR. After equalization, we found indeed that the DPR was pathologic 0.84 in the distal diagonal, whereas it was not significant 0.95 in the left main. Then we disconnected the OptoWire, we engaged the RCA ostium with the guiding catheter, we reconnected the OptoWire and found that the equalization was still stable with DPR. And indeed, we checked with DPR the posterolateral and it was not significant. So we decided to not treat the posterolateral, not treat the left main, and leave the diagonal for a staged procedure, TAP stenting, in a few days because of the substantial amount of contrast already provided to the patient. The second case, it's also a routine case. It's an inferior Stemi with the proximal RCA culprit, suboccluded, and a mid-PDA non-culprit lesion. You see here the culprit, here the non-culprit. So what would you do? Would you do angioguided PCI with the proximal RCA, angioguided PCI with the proximal RCA PDA, IVUS-guided PCI with the proximal RCA and PDA, or DPR-guided PCI of proximal RCA and PDA?
So obviously also a very interesting case here, and as you noticed, the tortuosity of the right coronary artery was present there. You also noticed there were two lesions, one proximal and one in the PDA, so there are a number of questions involved here. Maybe I could start asking Giuseppe again, how important is it for you that you can use your pressure wire also as a workhorse wire?
It's a big novelty to be able to use the wire we use for functional assessment as a workhorse. First, because of its ease of use, and then because of its connect and reconnect capability. I think it adds to the smoothness of the procedure, and it increases your capability to appraise the patient multidimensionally rather than just relying on angio.
So do you have any experience with using these pressure wires as PCI wires as well? I believe that the older Abbott wire is a little bit stiff nowadays, but there are a number of newer wires that are more flexible.
Of course, some guide wires are better than others, and actually some operators have some preferences for specific guide wires.
I typically rely on BMW, just like you were using your standard motorbike or a standard car. But we actually did use OptoWire as a whole course guide wire in Stemi cases, and found it was very easy, very user-friendly, actually also for fellows. So the second case, the one we are expecting the results for, actually was done by a fellow as first operator, and you will see what we actually did.
Thank you. Then, of course, there is the question of the two lesions in the right coronary artery. Both of them could be the culprit, and you assumed that the proximal one was the case, which also angiographically looked so. But let's assume that you can use pressure wire in the acute setting. How would you address the fact that you have a serial stenosis? You have one lesion in PDA and one in the proximal RCA. Is that a problem?
Well, of course, there is a problem of the summation of the two lesions, and you typically would need to do a pullback and check where the biggest drop occurs. As Peter Smith was saying very, very smartly, you cannot rely on a negative results, so non-significant results acutely, but you can rely on a pathologic result. You can see actually very well the angio. The angio was, for the second case, was clearly pointing to the RCA proximal as the culprit. And also, I think you can integrate with the DKG and the echo and the clinical features of the patient. When in doubt, I think you should rely on angio. We actually have seen the recent results of the flower MI. The angio is always what we should trust more. But I think DPR or FFR or IFR, whatever, functional assessment comes handy whenever you are not that sure and you want another perspective to address the patient.
Okay, thank you. And actually 46% voted for an angio-guided PCR of the proximal RCA. 30% would do both the RCA and the PDA, and the two last options were not that popular. Now let's assume that we do the proximal RCA because this is the obvious culprit. Do we need to do the PDA? I mean, it's a relatively small territory, Peter.
Correct. Well, of course, you can only establish whether the patient has complaints or ischemia afterwards. But when the patient is already on the table, potentially a complete revascularization is maybe better, as seen also in the complete trial. So, although it might be not such big territory, I would proceed by treating the proximal and proceed then by treating the PDA as well. Whether that can be angio-guided or physiology-guided, I think both are equally good.
Thank you. Zsolt, do you have anything to add here? Would you do PDA subsequently, or?
I was answering a couple of questions from the audience, and one of which pertains to the flower MI trial, yes, which was actually launched just a couple of days or weeks ago. So the one of the audience actually members asks about how we interpret these results. So I think this is something that we should discuss if time allows.
Yeah, maybe we can do that now. How would you interpret the results?
Well, it's disappointing to see that an FFR-guided PCI strategy does not meet its primary endpoint. It has a number of questions, of course, and the generalizability of the trial is questioned. Also, there's a cost-effectiveness analysis which pertains to France, if I'm not mistaken, which may be the same thing. But I think we should concentrate rather on the main findings of the clinical findings of this trial. What do you think, Peter?
Well, what I noticed in the trial, and that was, I think, a little bit a missed opportunity, is that they did not assess, they did not use physiology at the index procedure. And I think that is where the benefit maybe is the best. in the flower MI ended up being a staged FFR-guided trial. Although it was not that was not the purpose. It was not the setup of the trial. It ended up being a completely staged, almost completely staged FFR-guided versus angio-guided trial. And actually, the beauty of physiology assessment at index is really helping you whether you should treat acutely or staged the other non-culprit lesions. If you can do the physiology at index, then you you can really help maybe one third or up to almost 1/2 of all your STEMI multivessel patients by preventing them of having a staged procedure. Because if you can do the physiology at index of the other non-culprit arteries or non-infarct-related arteries, and those lesions are not physiologically important, then those patients you can send reliably home, and don't need to have them come back for an additional invasive procedure with some additional risk. So in that respect, I think the flower MI is still is a nice trial, but it missed a nice opportunity.
I think also, if you notice that the event rates are very low, and in the angio-guided arm, you implanted twice as many stents as in the FFR-guided arms. Given the fact that the event rates were so low, probably stenting or no stenting did not mean that much to the patient from a prognostic point of view. So if you are the devil's advocate, you could say that it only shows that newer drug-eluting stents works very well. It does no harm to the patient. But after all, the difference between the two groups were not that big regarding treatment. And there must have been a number of minor ischemic areas that have been included, which makes no difference after all. I don't know what you say to this. Could that be a perspective, the very low event rate?
Definitely, and that was also the comment of the Lancet itself, that in journal, actually, sorry, that the confidence intervals were rather wide. So the trial is not that conclusive, actually, and that was more or less what New England Journal was saying, that the conclusion should be limited for the fact that the event rate was low and the confidence intervals were large. So the trial could go could go many ways.
And also the inability for the angio guidance to defer stenting if not needed may not show up in such a short period of time. This was a 1-year endpoint, and if you go 5 or 10 years out the timeline, it may be a different issue. So still, I believe you shouldn't stent a non-ischemic lesion. Okay, shall we see, Giuseppe, how you actually treated case number 2?
Basically, we did the following. We wired the RCA using the OptoWire. Then we performed equalization. We disconnected the OptoWire and used the OptoWire just as a workhorse guide wire, just at BMW. Performed POBA and then stenting of the RCA procs, then reconnected the OptoWire and found that equalization was perfectly stable, and checked with EPR the distal PTA and the mid RCA. They were both not significant. Indeed, we are aware that the sensitivity of DPR is not very high in the segments distal to the culprit lesion, but specificity remains high. In conclusion, Opsens DPR technology is very promising for the invasive assessment of the functional significance of coronary lesions in stable as well as unstable patients. The technical features of OptoWire III, minimal drift, connect-disconnect capability, once-only equalization, torqueability, make it an appealing guide wire for STEMI patients with multivessel disease. Routine use of OptoWire III can prove beneficial for all operators aiming at achieving functional complete revascularization of STEMI patients. enabling index as well as stage appraisal and revascularization of culprit and non-culprit lesions. I thank you, and I thank the team at Santa Maria Goretti Cath Lab, and remain open for any inquiry or question. Many thanks.
Thank you very much. Two very interesting cases. Thank you. Now, obviously, we have discussed the flexibility of the wire and the importance of using a wire for multiple lesions, which, of course, is especially prominent in multivessel disease. Could you, Giuseppe, tell us a little bit more about the connecting and disconnecting of this Opsens wire?
The features of the wire itself, the mechanical features are very, user-friendly, very foolproof. It's like putting a torquer or removing it. It's very easy to connect and disconnect. And we were actually surprised while using it because we forced the use. We used humid tissues. And the procedure itself was done by a fellow and not a very accomplished one, actually. So a good fellow, but not the best ever. And I think the guide wire is very, very user-friendly, very torqueable, and very forgiving, even in challenging cases.
And then talking about the technical aspects, one thing that we need to touch upon is drift. Peter, is it important if you have a low drift rate?
Yes, I think it's very important. It makes you more secure about your procedure, about your findings, of course. And I think drift is getting more and more important if you rely on resting indices. Then I think the drift has an even bigger impact. So certainly, if I would work with a physiology-guided system, I would definitely would favor the one that has the lowest drift.
Yeah, maybe we can also come back to this issue later on, because now I'd like to introduce the second speaker, Dr. Jacques Monsegu from Grenoble, who will now give his talk on revascularization in Stemi and focus on whether it should be staged or could be done in the acute setting.
Complete revascularization in multivessel disease patients with Stemi is actually a great challenge and asks especially two questions. First, which non-culprit lesions have to be treated and when? If the timing depends on several factors, as lesions complexity, patient age, renal dysfunction, my preference is in favor of a stage approach to treat non-culprit lesions. A strategy of physiology-guided non-culprit lesions assessment is now clearly validated even during the acute phase. So I propose to share with you a clinical case where we have guided our strategy with Opsens OptoWire in a complete stage Stemi revascularization. It's a simple case of a man, 64 years old, with usual risk factors, who was admitted directly in our cath lab for an acute inferior Stemi. Initial angiogram showed a 3-vessel disease with a 2-vessel culprit lesion, right coronary artery and distal circ, but also a significant mid-LED stenosis, an intermediate proximal LED lesion, and a proximal circ lesion on bifurcation with obtuse marginal. We perform immediately culprit lesion, both right and circ, with a good result and a resolution of pain and ST elevation. The procedure was a little long, and we decided to stage complete revascularization a few days after with a physiology-guided strategy using OptoWire II from Opsens. if the third OptoWire version is now available in Europe, it's not reimbursed now in France, explaining why we have used OptoWire II. This fiber optic sensor has several advantages: a concentric design allowing spinning precision, and a very good transmission with a nitinol core, which provides strength and flexibility. We decided to start by Circ Evaluation. First of all, you see on the video that there is it's very simple to prepare the wire using the needle just to obtain a nice tip shape. And after that, the navigation is really very easy. In this case, assessment by DPR of proximal circ with the wire in distal circ was negative, not surprising according to a small infarcted area. So you see the DPR was strictly normal. After that, we decided to assess the proximal circ lesion with the wire in obtuse marginal, and you can appreciate the easy navigation through this tortuous vessel after disconnecting the wire. Then we inject adenosine, and after decannulation with the guiding catheter, you see that we have a very positive result with FFR is very positive, 0.73. So we decide to do the PCI of the circumflex, proximal circumflex through the marginal with the drug-eluting stent after a sequence of port, side branch opening, and report with a good result. After that, and with the same wire, we decide to assess LED lesions. As you can see, the DPR evaluation was very, very positive, witness to a very large ischemia on the anterior wall with the DPR. DPR was 0.50. So very positive. We do the revascularization with a stent implantation with result was correct. But when we assess again the LED, we have always a positive DPR with a result 0.80. So after that, we decide to treat the proximal LED. You see the pullback. It's very interesting that we see the jump just at the ostium of the LED, and the DPR was always positive. So we decide to treat proximal LED with the third stent with a very good result. And after stent implantation, we did a final evaluation with DPR, and the DPR was negative 0.92, and we are very, very lucky. So in conclusion, in this case, we have shown a feasibility and efficiency of stage physiology-guided revascularization for Stemi on multivessel disease patients. And this case demonstrates the quality of OptoWire II from Opsens. We succeed to do all the treatment, all the evaluation with the same wire without drift, and we do a pre-PCI assessment with FFR, DPR. After that, we use a DPR pullback to evaluate, to assess the LED, proximal LED. And finally, we assess the post-PCI with the same wire. So I think it's very interesting, and it's open to the discussion. Bye.
Thank you very much, Jacques. A very interesting case. A number of questions to be asked here. And I also, in a little while, want to go back to the technical features of the measurement itself and the wire. But maybe first of all, did you consider CABG for this patient?
Oh, excellent question. No, we don't consider CABG for this patient. First of all, because when he arrived, he had two vessels occluded, and we do the revascularization of the culprit lesion. And so after that, we have a young man with a syntax score low because RCA was treated and the distal Circ was treated. It's a non-diabetic patient. And we have focal lesions on the Circ, proximal Circ, even if it's a bifurcation. And we have on the ADD, mid-ADD, very simple lesion, a short lesion. And also after that, we evaluate the proximal LED, which was disease and which we treat. But finally, it's short lesions, and we had only three stents, for treated all the lesions. So we don't consider CABG in such a patient, and I'm always afraid to give a patient after a first revascularization by PCI with a dual antiplatelet treatment, and to move to the surgery very quickly. So for me, it's not a real indication.
Thank you. And I think also you have to admit that you don't have a full overview of the patient before you've done the physiological assessment. So I totally agree. And then, of course, Peter, the question directly to you, being the PI of the COMPARE-ACUTE study, should these patients be staged when you revascularize them fully? I mean, you don't know the renal function when they are admitted, and you may already have used a lot of contrast for the culprit lesion, or can you immediately go ahead and do the complete revascularization?
Well, it's a very good question, and actually there are multiple points to take into account. First of all, of course, the condition of the patient after you have treated the culprit lesions. Is the condition of the patient still good? Is he stable? And did you not use so much contrast? And was the procedure uneventful? All these things you should take into account whether you proceed acutely or you do a staged procedure. If I heard from Jacques that the procedure on the right and circumflex went quite fast, then potentially you could proceed by doing the physiology assessment of the circumflex and the LED in the acute phase. I think that's quite doable, and that will not take too much time or contrast. And at least you know whether you should do something extra or not. In this case, both lesions were significant. And then the circumflex, of course, it was a kind of a bifurcation lesion. The LED ended up being actually more or less two lesions. Potentially, a staged procedure in that case would have been also a very good decision.
Then maybe I would like to go a little bit back to the technical features and refer to a study from London in which they simulated 2 millimeters of mercury of drift and found that in 20% they misclassified patients when they used FFR, and in 20% when they used the diastolic index. So 2 millimeters of drift means a lot. So there are questions in the chat asking if the hydrostatic errors is a concern when you use resting index. Is it so?
Well, if I may.
Yeah, you may.
It's not a meaningful issue, in my opinion, in these patients. First, because there is no perfect index. So if you go back historically, we have FFR, which was validated with SPECT, and then we have trials, but trial stable patients. We have other tests which are drawbacks. Now, the standard of care for many is IFR, But IFR is not a perfect agreement with the FFR either. So I think there are some issues. Of course, also I think that we also, going back to the flower MI, there is a problem that we sometimes want to delegate our responsibilities to angio or to an estimation. But as you can see, sometimes you get a DPR of 0.88, another time the same patient 89, and this applies to FFR, IFR. So I think that it's not a yes or no issue, and some patients may have technical issues. Our experience has been very satisfying with the wire. At odds with the IFR or other devices which showed some lack of repeatability and reliability over multiple measurements.
Thank you. And then there is another question which I also think we can touch upon. It's maybe a little bit outside of the scope, but nevertheless, the question briefly is the fact that if you have treated, for instance, the circumflex as a culprit lesion, and you have a stenosis on the LAD, which by means of collaterals also supply RCA-CTO, can you rely on the FFR that you measure in the LAD, or the diastolic index for that matter?
I would like Peter or Zsolt to try to reply, because I'm much less an expert in this.
Well, of course, you can rely on your physiology assessments, but you should take into account that the moment you also open up the right, the FFR of the LAD might not become not that significant anymore. So that is always, you have to take into account the size of the vasculature. If it is large, because if the feeding vessel is also providing blood flow to a occluded vessel by collaterals, your IFR or your resting as indices, DPR or IFR, and even though your FFR is higher than is more significant, of course. Yes, it's reliable, but take into account that the fact if you open up the collateral vessel, the indices might drop, might become less significant.
I may just add one thing. I think if it's a massively positive FFR in the donor vessel, even if you open up the CTO of the contralateral, most probably the FFR will remain positive. So we don't have really definitive evidence in this respect. But there are some communications showing that the CTO, yes, it impacts all physiologic indices, but not that much. So an FFR of 0.60 in the LAD, giving contralateral flow to the occluded right cornea, will probably remain positive even after opening the CTO or grafting it for that matter. So the question that I received in writing was that, should the surgeon be considering grafting an intermediate LAD if it gives rise to contralateral channels to the occluded right? I answered, you should do a hyperemic pullback most probably to see how much pressure drop is caused by the intermediate lesion in the prox LAD. And if it's large enough, yes, I think the surgeon is entitled to graft it, especially with an Lima graft, which is less prone to occlude. So it's, I think it's a difficult question to answer, especially evidence-based, in an evidence-based matter.
Thank you. We are already 1 minute behind time, so I would like to thank everybody for their participation, and obviously multi-vessel physiologically guided PCI has come to stay. There are a number of unanswered questions. When should it be done, in the acute setting or in a staged fashion? But obviously you need to have a solid equipment to rely on these multiple measurements. So thank you very much for your attention, and thank you very much for the participation, and have a nice evening. Goodbye.